Dr. Jeff talks love, Dr. Jeff talks life, answers your questions, cuts through the strife. Sex and intimacy, real and true, evidence-based, made just for you.
Hello. Welcome to Dr. Jeff Talks About Sex and Intimacy, the podcast where we explore the real, raw, and relevant aspects of sexual health, relationships, and everything in between. Thank you. Thank you so much for joining us today live or on the recording for episode 35, Men's Health, Erectile Dysfunction, and Male Mortality. I want to sincerely thank you for taking time out of your busy life to learn more about this topic. You are the reason that this podcast exists, and we so appreciate you tuning in. So thank you. We're on social media. If you didn't already realize, we are out there on your favorite streaming social media, that is for sure. So you can pick us up. We're on Facebook, YouTube, X, LinkedIn, Kick. If you're on X and you have a question, go to YouTube, LinkedIn, Facebook, Kick, or StreamYard to ask that question and submit it, and we will feed it to our guest this evening. If you're a Facebook person, we always need followers because the more followers we have, the more we can do on Facebook. So please follow us on Facebook if you are a Facebook person. Go to the website. When you go to the website, you are going to see that you can watch any of the previous episodes. We have amazing episodes with all these great, excellent guests who have so much information to share with you. You can pull up the calendar on the website and see what's coming up next and find out exactly what we have in store and what you might want to tune into. So please go to the website. In addition, while you're working out, while you're in the car, listen to us in the car, wherever you are, we're there with you. We're on your favorite music streaming service like Spotify, Amazon Music, iHeartRadio. If you're there, we're there. You can listen. So please do. Well, the goal of the podcast is simple. It's very simple. It is to empower and enlighten you with the information you need, evidence-based scientific information to improve your sexual health and deepen your relationship, helping you live and love more fully. Who doesn't want more of that? So that's what the podcast is all about. Well, we've had several healthcare experts, including Dr. Kira 2 weeks ago, to talk about sexual health and overall health, because sexual health ties into overall health. And tonight we're going to zero in on men's health. We're going to get to the heart of the matter, literally. And we're going to also talk about sexual wellness. Sexual health and overall health are really important. Sexual health doesn't exist in isolation. It's deeply linked to cardiovascular health, hormonal balance, mental well-being, and overall vitality. As you've heard us say in other podcasts, erectile dysfunction is not only a sexual issue, but it's often one of the earliest indicators of cardiovascular disease. Joining me to dive into this critical conversation is a colleague and friend of mine, Dr. Martin Miner. He is a leading expert in men's and sexual health. He is co-director of the Men's Health Center at Merriam Hospital in Providence, Rhode Island, and an associate professor of family medicine and urology at the Warren Alpert Medical School of Brown University. Dr. Miner is a past president of the American Society for Men's Health and has authored numerous scientific publications on male sexual health, cardiovascular risk, hormone therapy, and healthy aging. His pioneering work has helped shape how healthcare professionals understand the interplay between sexual function and overall men's health, making him one of the foremost voices in the field today. I can't think of anyone better to speak to men's health and helping us understand the real challenges of increasing and decreasing men's mortality and increasing longevity in men. So I'm super excited to welcome Dr. Martin Miner. Welcome, Marty.
Hi, Jeff. Great to be here.
So glad you're here. Looking so forward to your excellent information. I saw it ahead of time, and I'm going to hand it over, and the audience is all yours, Marty.
Okay, let's go. So I wanted to briefly speak about erectile dysfunction and male mortality. And most of us know that there's a tremendous gap in survival between men and women. In this country, men live about 5 years less than women. And these are my disclosures. And gender differences in regards to mortality and life expectancy vary by country, but in most, men do live shorter lives than women. For example, in Russia, that difference is 13 years, and in the US, that difference is 5 years. But what's behind this male-female gap in life expectancy? And this is actually one of the things that really established my interest in men's health. We all know that men are more likely to engage in risky, unhealthy behaviors. There are higher rates of smoking among men, heavier drinking, gun use. Almost all of the school shootings that we see involve younger men. Employment in hazardous occupations, and risk-taking in recreation and driving. But I'm going to suggest that this gap in life expectancy may be a result of poor cardiometabolic health. And in a study by O'Hearn in the Journal of the American College of Cardiology, published in 2022, it notes worsening trends from 1999 to 2018 in what we call cardiometabolic health. Only in 2017 and 18, only 6.8 of American adults, men and women, had good cardiometabolic health. And that has declined in 20 years from 7.7%. And disparities by age, sex, education level, and race and ethnicity exist. And much of this is related to diet, healthy weight gain, and poor glucose levels, which are worsening. We know that about 40 to 45% of Americans are obese. And in the southeastern trend of the country, this is actually close to 60%, which is true in Texas. So the real pandemic has been 4 decades in the making. 50% of US adults have hypertension. 50% of US adults have diabetes or pre-diabetes. 40% of US adults have dyslipidemia or elevated cholesterol, and 75% of adults are overweight and or obese. That is quite significant. So chronic disease in the US, specifically those individuals who have diabetes and pre-diabetes, almost 30 million Americans have been diagnosed with diabetes, and about 10 million more have undiagnosed diabetes, and 115 million Americans are pre-diabetic. So that means that almost half of Americans are diabetic or pre-diabetic. And the treatment costs for this disease state alone is over $350 billion annually. And that's the pre-GLP-1 agonist phase of treatment of diabetes. Obesity, as I said, prevalence is about 42%. Severe obesity being about 10%. And the prevalence of obesity increased in 1999, 2000, from 30.5% to 42% in March of 2020, right when the pandemic hit. And the prevalence of severe obesity increased from 4.7 to 9.2%. What does this mean? This means that 42% of Americans have 2 or more chronic medical conditions, specifically type 2 diabetes, obesity, and hypertension. And the problem is that the United States currently has a sick care healthcare system. And the cost of chronic medical conditions and their treatments has spiraled out of control. And we have to move to a system grounded in primary prevention and restorative health. And how do we get people interested in the concept of self-care? For me, in my clinic at Brown University, what I've always found is the key lever is male sexual health as a key to men's health. So we all see advertised on TV the low-intensity shockwave centers and the centers to treat Crohn's disease with low-intensity shockwave. And these call themselves men's health centers, but there's nothing healthy in reality about them. They charge between $2,000 and $4,000 and make all sorts of promises, but none of them speak to a man about their sleep, about their stress level, about their diets. They all just give these tailor-made treatments that often don't work. And we see Doug Flutie and Frank Thomas, great athletes of the past, who play into men's fears regarding aging and talk about the romantic nature of eugenics, which has never been shown to do anything about increasing testosterone levels with aging men. And I want to go over briefly about the relationship between erectile dysfunction and cardiovascular, because that was one of my first key interests and one of my first research areas that I wrote about. Erectile function, as Jeff indicated, is a predictor of cardiovascular morbidity and mortality. And this factor remains after the adjustment for common comorbid disease conditions. It's actually an independent risk marker. It's not strong enough to be a risk factor, but a risk marker. And ED, or erectile dysfunction, represents an early symptom of endothelial dysfunction, which I describe to patients as elasticity of the vessels. It's also part of smooth muscle dysfunction and atherosclerosis. And the identification of patients with erectile dysfunction offers an opportunity, at least in my clinic, for early risk-adjusted treatment with the goal of further reducing cardiovascular events. And you can see men's health and sexual medicine all revolve around erectile dysfunction, low testosterone, and lower urinary tract symptoms secondary to benign prostatic enlargement. But this includes mental health, behavioral modification, urologic diseases, metabolic, diabetes, and cardiovascular disease. And these all incorporate lifestyle and lifestyle adjustments. Penile anatomy reveals the need for appropriate vasodilation with arousal. You can see these vessels, these arterioles, and dilate with the release of nitric oxide. And with that dilation can occlude or block the veins from leaking out, and a man can maintain his erection in a very healthy state. This is the endothelium. These are the endothelial cells that we talked about. And this is the arterial lumen. And you can see it involves smooth muscle. This is a healthy endothelium. many endothelia in men who are 40 years of age are quite ill appearing. They have lost their smooth muscle. They have scarring of the endothelium with smoking. Early in 2004, Kevin Billups, who was at Johns Hopkins at that time, he looked at 30 men with erectile dysfunction and no clinical cardiovascular disease and 27 age-matched controls, and he measured endothelial wall or endothelial function through brachial artery ultrasound. And what he found was that there was a significantly reduced in erectile dysfunction of endothelial function. And this was the first study of its kind that showed that men with erectile dysfunction have impaired endothelial dysfunction. Then in 2005, Ian Thompson, the University of Texas, in the prostate cancer prevention trial, looked at 9,500 men. And in the placebo group, those men who did not receive a 5-alpha reductase inhibitor to shrink their prostate, and he examined them over 10 years. And what he found is that new onset or incident erectile dysfunction had an equal or greater effect on subsequent cardiovascular events, the same magnitude as traditional risk factors, that men with new onset erectile dysfunction were the same as having a family history of premature cardiovascular disease. And that new onset erectile dysfunction predicted a cardiovascular event in 11% of men up to 7 years prior to the occurrence of that event. So ED is clearly a predictor of future cardiovascular events. We put out 4 iterations of the Princeton guidelines, which were developed for clinicians to help them manage erectile dysfunction and cardiovascular disease. It started 25 years ago when sildenafil or Viagra was introduced, and men were dropping, or about 160 men had experienced death during coital activities or during intercourse. And what's known is that sex increases the baseline risk of an MI from 1 to 1.01%, 1 in 10,000. And the risk of sudden cardiac death is 1 per 10,000 person years. Normal sex is 2 to 3 minutes, so you have to be able to climb 2 flights of stairs or walk 1 mile in 20 minutes. But intense sex is about 5 to 6 minutes or 4 minutes of a standard boost protocol on the treadmill. So Princeton 1 through Princeton 10 developed recommendations for clinical management of sexual dysfunction in patients with cardiovascular disease, while Princeton 4, which we just published about a year and a half ago, continues the development of these recommendations with highlights to use the atherosclerotic risk calculator to determine whether or not a person needs statins or not, to utilize a coronary artery calcium score to also determine whether or not a person needs a statin. And the role of PDE5 meds, which are what tadalafil or Cialis and sildenafil or Viagra are. These meds, and we'll talk about that in a few moments, actually protect against cardiovascular events. What's known is that 1/2 to 2/3 of young men who have MIs have no erectile dysfunction. But many men with severe ED will never have an MI. But ED severity is strongly linked with cardiovascular disease severity and coronary occlusion. And like I said, ED is a risk marker or risk factor for cardiovascular disease onset. During COVID, telemedicine, Roman and hymns grew like lightning. And my concern about these is that with telemed platforms, are we missing an earlier opportunity for cardiovascular risk presentation? I've actually been an advisor to HIMSS, and they launched the Polypill, which I kind of spearheaded, which is a heart booster, which includes a statin plus tadalafil. This rosuvastatin-tadalafil combination is responsible for part of their income revenue, which is $2 billion of ED drugs sold annually. A lot of young men, my son's age, really want to get their treatment in medicine through their phones. And observational studies show that when we used to believe that it was vascular ED that really correlated significantly with future cardiovascular events, but many younger men and older men alike suffer from psychogenic or performance anxiety. And what we found is that psychogenic ED or performance anxiety also is a harbinger of increased cardiovascular risk, not dissimilar from vasculogenic ED. And men with psychogenic ED are likely to benefit from cardiovascular risk assessment and management and risk mitigation, and more research is needed. In 2019, in Circulation, we published a paper about erectile dysfunction as an independent, that means by itself, without any other comorbid disease states, as an independent predictor of future cardiovascular events. And we used the MESNA study, the multi-ethnic study of atherosclerosis, which is an ethnically diverse, community-based cohort. And this showed that ED is a significant independent predictor of future cardiovascular risk. And we developed this Princeton 4 consensus, which I'm not going to go into now, except that if you ever have an opportunity to ask your doctor to order a CT calcium study, if you've never had this, it takes 2 minutes and it's very limited in radiation exposure, the equivalent of about 2 mammograms. And what it shows is the calcified plaque in your heart. And you're given a score of 0 to 400 or beyond. And this is a marker of how much subclinical plaque you have. And it's this way that we've discovered many men who have significant subclinical coronary disease that have erectile dysfunction. And given the connection between erectile dysfunction and coronary disease, it's logical and strongly supported that erectile function can be improved by lifestyle, by a healthy diet, by exercise. I'm talking about primarily a vegan diet, weight loss, tobacco cessation, and stress reduction, and improved sleep. And improving erectile function with both lifestyle and pharmacologic interventions may reduce atherosclerotic risk and future cardiovascular events. This is what we talked about, the impact of these meds, Viagra and Cialis, on cardiovascular outcomes. Since 2017, there have been 24 publications that show these meds reduce future cardiovascular events. They're all cross-sectional studies, so they're not randomized, double-blind, placebo-controlled trials, but we can see that they do reduce future cardiovascular events, and they're all very strong in doing so. In this particular paper by Bob Kroner, who's a cardiologist, formerly of USC, now at a private scientific institute, and Ray Rosen, there was a 13% reduction in major adverse cardiovascular events, which include heart attack, stroke, and other, and a 25% reduction in mortality with the use of sildenafil. And in this particular study, even higher use, those men who use these meds more often had a greater reduction of MACE or events and a greater reduction in mortality, both close to 50% or above. These are the papers that we published in the Princeton 4. And based on 20 years of unyielding evidence, we determined that ED is this independent risk marker for coronary disease. If you have blockage in your penis, then you're going to have blockage in your heart, although it might occur earlier in the penis. This is a paper that was published in Clinical Medicine last year. The association of tadalafil exposure with lower rates of MACE and mortality. And in this particular paper, tadalafil exposure was associated with an overall lower mortality rate of death by 44%. And in this paper, which I've been showing patients all the time in my office, it's a longitudinal study of 50 million men from 2004 to 2021, 510,000 patients over 17 years. Tadalafil and sildenafil were associated with reduced risk of all-cause mortality, a 34% reduction in death, a 27% reduction in heart attack, a 34% reduction in stroke, and a 32% reduction in dementia. And tadalafil shows more reduction in these overall positive rates than sildenafil. Cialis reduced the rate of events, probably because of its longer half-life and the fact that men can take it on a daily basis. This is that paper that I was telling you about that was published in Mayo Clinic Proceedings. It was published last year. We look at erectile dysfunction as a fulcrum for lifestyle change. It's a basis when men experience it, regardless of age, they should begin a diet and exercise and lose weight and manage their blood pressure aggressively, manage their lipids aggressively, i.e. their cholesterol, stop smoking, manage their diabetes, and hopefully reverse their diabetes, and that we can determine how much plaque they have by doing CT calcium scores. And among all men, we can potentially reduce the death from heart disease by close to 40%. We can reduce angina by 22%, heart failure by 17%, and revascularization, that means stent or bypass surgery, by 15%, with the use of these medications and lifestyle. So those are my brief remarks, and I'm open to any questions or discussions. In summary, I just want to say that agreement exists regarding the high prevalence of ED in individuals at risk for cardiovascular disease. ED status is included in one risk predictor, and that's in the UK. And CT calcium can discriminate regarding potential therapies, and possibly there's a role for the treatment of ED for PDE5s to reduce overall cardiovascular risk, also low-dose aspirin, and the GLP-1 agonists like Ozempic and Wegovy and tirzepatide. With that, I'll end. Thank you.
Wow. Wow, thanks, Marty. That was awesome. So much great information. It's amazing how over the last decade, study after study has really talked about um,
Right.
the link between erectile dysfunction, cardiovascular health, and how these indicators. And when you look at you look at that information you presented, 50% of people have the high blood pressure, 50% diabetes. That's a lot of folks. People always say,
Yeah.
gosh, it seems like it's part of aging to get erectile dysfunction. But what happens is as we get older, we get high blood pressure, we get coronary artery disease,
Right.
diabetes, cholesterol issues, right?
Right.
And all of this impacts quality of life and quality of sexual function for both men and women. So I think
Absolutely.
you really drove those points home. I love how you talked about and regularly I talk in my clinics every day. We work on diet, that Mediterranean, low fat, low cholesterol, low carb, low fat, high fiber, plant based diet. We know if it's good for your heart, it's good for your erections, right?
Right. Absolutely.
And then that exercise, it was amazing in the Princeton 4 how they talked about 150 minutes a week of cardio. Cardio is super important in this case.
Right.
In improved erections in 20 by 20% in men, and
Right.
300 minutes a week in about 40% of men. Improved erections by 40%. Just fascinating information on how important that our bodies were designed for and made for cardiovascular exercise, to move, to hunt, to gather, right?
Right. 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 Yeah.
And so I think that combination, that triad of diet, exercise, and weight control is incredibly important.
One
And
more thing, sleep. It took me
and
years
and
to
yet I
learn.
was getting to that. I love that you talked about sleep, because so often my patients struggle with sleep, and we're both older, so we were talking earlier about getting into these retirement years, and sleep seems to change as you get older. When you were young, you would sleep for 12 hours and wake up in the same position you were in at 18 that you fell
Right.
asleep in, right?
Right. Right.
Now we toss and turn, we get up to go to the bathroom. Sleep is so important, getting you that quality sleep. While you sleep, your testosterone it builds up and increases. Your nitric oxide synthesis, all kinds of good things. Your erections, your penis works out while you sleep to keep itself in shape.
Absolutely.
So
Absolutely.
many great things happen while we're in that REM stage of sleep. So I agree, sleep. And then, I'm always preaching smoking cessation, smoking anything. These days, they're like, well, I don't smoke cigarettes. Well, whatever you're smoking, especially vaping, whatever, please stop, because study after study keeps coming out telling us not helpful, not healthy.
Not healthy.
Um,
No.
nicotine actually vasoconstricts those blood vessels, decreases nitric oxide synthesis, and decreases sensation on the penis. In Europe, they have these great ads with men standing against the wall smoking the cigarettes, and as the women walk by, the cigarette goes whoop.
Right. Right. I've seen those. Those are great. Yeah.
Very effective ad campaigns to help people
Yeah.
know smoking cessation. So diet, exercise, weight control, sleep, really good quality sleep,
Pillars.
and then smoking cessation,
Right.
minimizing alcohol, recreational drugs, things like that.
Right.
Yes, so important, and the message that we talk about so frequently here. I have a couple questions. The first question is this: many men are hesitant to bring up sexual concerns with their healthcare providers, but what advice do you have for breaking that silence? How can you help patients know how to start that conversation?
Well, that's a very good question. And I think many providers hesitate to bring it up because they're fearful of the take. And it really doesn't. It doesn't take a lot of time. If you're experiencing a change in your erections and it's disturbing, we all wait for the doctor to ask us about it, but very few doctors ask about sexual function. So I would just say, Doc, I'm really having some trouble in the bedroom lately. I'm having trouble with my erections. What advice would you have for me? And know that, they might be quick to prescribe a medication, where the medication may be of great value, as we've talked about here, that it may also lower the incidence of future cardiovascular risk and poor outcomes. That it's not just related to that. Most doctors, most of us give lip service because we just don't have the time to all of those pillars of lifestyle. But those are key in addition to the medication. It's not just the medication. So acknowledge what's going on, bring it up, be very blunt, and if your doctor wants to prescribe a medication, I would suggest using a daily low dose They're very few if any side effects. Very well tolerated. And it could be protected.
Yeah, great advice. I think sometimes if you want to watch, I'm not sure your microphone, if it's falling down a little bit on you, but it's kind of making a little noise down there or something sometimes. But but I was gonna say, I think it's as simple as just, and here's what's so interesting. We see with primary care, with oncology, even with nurses as well, there's no doubt that most of them aren't going to probably bring the subject up. We want them to, we would love for them to, like we do in our clinics, but there's so many things to talk about in your primary care office and so many things to talk about in your oncologist office or your cardiovascular doctor's office. So talking to your provider, your advanced practitioner, your doctor, whoever, about these things is so important. And it's as simple as just saying, I know that 1 in 5 men in their lifetime struggle with erections, and I'm having some difficulties. Can you point me in the right direction to find out more about what to do about that?
I think it's actually higher than 1 in 5. I think it's closer to 50% or above.
Yeah, I think you're right. And that's 1 in 5 lifetime. And you think, wow, by the time you're 70% of men, 80%. So I think you're right. Of course, we know, because so many of the men who walk in our office are struggling with erectile dysfunction, but it can be that simple. And do not be embarrassed. There is no reason in the world to be embarrassed. You're not alone. So many men out there. Remember, by the time you're 60, half the men in your age group are struggling with erections for sure. And again, like you said, Marty, not everybody's talking about it. It's not something everybody's going to admit to. So it's probably higher than the statistics even say.
Oddly, I find that many men are ashamed because they think it's and it affects the couples, because many in heterosexual relationships, many partners, female partners, feel that they're not attractive anymore and that their man is not attracted to them, and that's why they're having this difficulty.
It's so interesting how all of us, we're like hardwired in our brains to go to, it's something that's wrong with me. And it's nobody's fault, the erectile dysfunction. It's not the person with the erectile dysfunction, and certainly not you. But I agree, in heterosexual and homosexual relationships, I found in my patients as well, the partner's always like, I thought it was me. He used to love sex, and now he doesn't really have interest anymore. And I thought, well, I've gained weight, this, that, or the. It's like, that's why I love to include partners in my assessment of patients with sexual dysfunction. So it's important to bring your partner along. But I do agree wholeheartedly that there's a lot of shame surrounding it. And there's no reason to be ashamed, but it feels very vulnerable to have a sexual problem. We don't think that much about sex and how it works until we're having a problem. And then it feels very vulnerable. And many of my men do feel shame, but there is nothing to be ashamed of.
No, but many of us universally feel that it's part of our self-esteem.
Yes.
If we're not functioning sexually and in a good way, we don't feel good about ourselves.
Mm-hmm.
And we can be doing everything else. We can be a great parent, a great employee, but we're just not happy with ourselves because it's so ingrained in ourselves to be a sexual being.
Yes. It's and I think too, it's part of the human journey. And what always sticks out in our lives, all the things that go good are wonderful, but what sticks out is the thing that's not going so well, and that's what's upsetting. But when it's
Right.
a sexual issue, it feels very isolating. But trust us when we say you are not alone. We
Right.
see countless men in our clinics with these problems, men and women both. I see in my clinics. And so I do think that you are definitely not alone in your struggles with sexual dysfunction. Remember those statistics. So don't be afraid to bring it up. And hopefully your provider will. But if they don't, no one advocates for you like you. I tell my patients all the time, nobody advocates for you like you. You are the best advocate in the world for yourself. Your partner's probably the second best advocate for you. So both go in there and make sure you bring up sexual issues with your provider. My other question that I had was this one. I thought it was a good question as well. What role can partners play in supporting men's sexual health? And how can my wife and I approach these issues together, we just brought up, without the shame or the blame, because it's nobody's fault?
Right. Well, there's one technique that I like to use of sensate focus, which is I have men, because men develop performance anxiety, and when they develop that flight or fight response during sexual intimacy, everything goes haywire. Everything goes down because there's vasoconstriction. After I explain the physiology, I tell them to buy some massage oil and set up a time with their partners, male or female, twice a week at least for 20 to 30 minutes, and just massage their partners in a non-erogenous zone. No breasts, touching of breasts, just back, shoulders, arms, and really focus on breath and breathing and relaxing during touch, because touch is so powerful, and we stop touching when we're having sexual dysfunction because we become very goal oriented about having it work during intercourse, as short as it may be, and keeping an erection, and that's the focus. And just to make it so that it's fun again, and that there's just a focus on massage, become the best masseuse possible. And your partner will truly enjoy it for 20 to 30 minutes twice a week, and you can alleviate some of that performance anxiety.
I think that's great. And we do use sensate focus. Yeah, I'd like to remind listeners, we've talked about before, anxiety creates adrenaline. Adrenaline is part of fight or flight. And if you get anxious, your blood's going to go out of your penis into your brain and your muscles and into fight or flight mode. So anxiety and sex don't go well together. We had a whole podcast on that with family therapists talk about that. So you can look back at that one, but they don't go together. And also, I love the point you brought up. We're so goal oriented, and we're taught the goal is intercourse, but intercourse is just one way. It's not the only way. It's just one way. And so getting back to sensate focus, we use it to remove the performance anxiety, because now intercourse is off the table. We begin with non-penetrative, non-genital, non-breast play, love play. And we do that all the time in my clinic as well. I think it's a great way to start. And then we slowly move back into genital play, and we remind people, all sex is great. Manual stimulation of the genitals, oral stimulation of the genitals, rubbing the genitals together, vibration, non-penetrative outer course is just as wonderful. So if you're hard enough, you could have intercourse, but if you're not, You can do so many different things with outer course or non-penetrative sex. And we will have a whole episode with a panel talking about that even further. We've talked about it before, and we'll talk about it again. With Dr. Susan Kellogg-Spatt, we talked about it before, and she's going to join us along with Alicia Williams to have a whole panel discussion on outer course and non-penetrative sex. But the whole thing is also maybe if you have a female partner, maybe they're having pain, or your male partner struggles with erections. So you don't have to worry about it. If you're hard enough to have intercourse, if you're not hard enough, there's a myriad of beautiful, wonderful things you can do in terms of outer course or manual stimulation. And like you said, move back to non-genital, non-breast play too. That can be great as well. So many good ideas and pointers, but yes. So I think we have hit on some really important things. We've gone through the questions. And so the only thing I would say is, I guess our biggest points to remind people are that diet, exercise, weight control, if it's good for your heart, it's good for your erections, sleep, good quality sleep, dealing with your sleep apnea, your insomnia, and getting and dedicating yourself to good quality sleep. I bet those statistics on sleep apnea are pretty mind-blowing too, because so many of my patients have sleep apnea. I'm sure yours do too. And so getting good quality sleep, and then smoking cessation, minimal alcohol and recreational drugs. Yes, so many good points. All right, we're going to go to a centering exercise, and then we will talk about what's coming up next. But if you've been on the podcast before, you know it's that time during the podcast to refocus, recenter ourselves. So, all right, before we close today, I'd like to invite you into a brief centering exercise to help bring this conversation back to your own body and your own well-being. Take a comfortable seat, and if you're able, place one hand gently over your heart. You can put the other over your lower abdomen. Close your eyes if you feel safe doing so. Breathe. Breathing so powerful. Take a slow, deep breath in, filling your lungs and abdomen. And you're expanding your chest. And then release it slowly, letting your body soften with the exhale. About 4 counts in, and about 4 to 5 counts out. Slowly exhale. As you breathe, notice the steady rhythm of your heartbeat beneath your hand. This pulse is your life force, your heart working tirelessly for you. Keep breathing. And now bring your awareness to the connection between your heart and your body's vitality, including your sexual health. With each and every inhale, invite in strength and energy and openness. With each exhale, let go of stress and worry or self-criticism. Let it go. We're our own worst critics. So with the inhale, invite strength, energy, and openness. With the exhale, let go of stress and worry and self-criticism. Remind yourself that you are beautiful, peaceful, and miraculous. Take one more deep breath, holding gratitude for your body and the wisdom it offers to you. Slowly exhale. Fall into a gentle, easy breathing pattern. And when you're ready, gently open your eyes carrying this awareness of connection and vitality with you into the rest of your day. I know many men are hesitant to bring up sexual concerns with their healthcare provider, but you're not alone. There's nothing to be ashamed of. You are a miraculous being. Don't be afraid to bring these up to your provider. Vic, let's show them what's up next week on Dr. Jeff Talks About Sex and Intimacy.
In this impactful episode, Dr. Jeff and Dr. Tracy Kurtzer discuss a critical topic: painful sex affecting millions of women. Painful intercourse due to vaginismus, vulvodynia, or trauma can severely impact a woman's confidence, relationships, and identity. Dr. Kurtzer shares insights into the causes of sexual pain and treatment options. This episode offers hope, education, and a clear message: you are not alone, and pain-free, pleasurable intimacy is possible. Join us September 9th at 7 p.m. Central Time.
Dr. Kurtzer is also an expert in trauma-informed care. We'll be talking a little bit about past sexual trauma. I will have my co-host, Dr. Susan Kellogg-Spott, who you saw last week, who did a wonderful job hosting in my absence while I was in the Northern Rockies. And she will join me next week with Dr. Kurtzer, and we'll have an excellent presentation on pain and trauma and returning to pleasure. But tonight, we had awesome information from my friend and colleague, Dr. Martin Miner. And thank you so much for sharing your expertise. Is there anything else you'd like to share with our audience as a final sum up of what you'd like to say?
Remember to ask about the CT calcium study if you've never had it. It takes 2 minutes and it's very inexpensive, and it does show you any amount of plaque that you have, so you can know. Most of us need to know how our bodies are doing.
Yeah, it's such a simple, non-invasive test that you can do that is such Yeah, it's a great indicator for that, and to know what's going on in those arteries, what's happening.
Right.
Because it's so prevalent in men, and we do want to decrease male mortality. And so that's really important. So I hope that you listeners have discovered just what you needed to hear, that you felt welcome, because all are welcome here. And we really appreciate your time and your attention to this really important topic. We as men are not the greatest like our female counterparts, but we need to advocate for our health. It's so important, and I think you've emphasized that beautifully tonight. So thank you so much for all of your expertise and sharing that with us this evening. And thank you, listeners. We're so glad you were here. Have a good one.
Who's Dr. Jeff Talks About Sex and Intimacy, breaking down the science, setting your spirit free with stories, wisdom, laughter, and care. Connection